Hello, my name is Michelle Sater. I'm currently a PhD student in translational neuroscience situated at the University of Aberdeen. My studentship predominantly focuses on emotion and hunger awareness in typical and pathological populations. Today, I'm discussing some of our interesting findings regarding the neuroanatomy associated with autism spectrum disorder, or ASD. ASD is a neurodevelopmental disorder characterized by behavioral repetition and difficulty with social interaction. It presents with a heterogeneous phenotypic makeup and diverse range of associated behaviors. A significant challenge in ASD research involves establishing standardized neural biomarkers associated with the condition. Multiple researchers have conducted imaging studies on those with ASD, but findings and associated regions vary significantly. Associations between ASD and age and sex are additionally called into question, and it's debated whether these factors impact volumetric findings. With extensive availability of structural imaging studies in those with ASD, we consider it pertinent to answer the question for ourselves and evaluate literature to establish condition-related biomarkers associated with autism. For this study, we decided to conduct a quantitative meta-analysis on studies conducting case-control voxel-based morphometry analyses. Literature was selected using Scopus, PubMed, and Web of Science. Our exclusion criteria comprised of publications older than 20 years, animal studies, publications lacking case control environments, meta-analyses reviews or non-imaging work, and publications not conducting voxel-based morphometry or including coordinate MNI results. Coordinates from publications were collected and input into GingerAile, and clusters depicting significance were visualized on a software known as Mango. Additionally, we conducted a separate small preliminary study using 40 individuals from the ABIDE-2 dataset, which were processed using FreeSurfer. In sum, we identified 47 papers with a total sample size of about 5,000 participants. Mean age was uniform across case-control populations at about 15.6 years of age. When analyzing brain volume, however, we identified no significant clusters associated with autism, neither independent of age nor when partitioned into age subgroups. A lack of findings highly contrasts expected findings when observing the initial input coordinates using Python. Results from our preliminary study on the ABIDE-2 participants corroborates our larger scale findings, with no significant differences in gray matter, white matter, subcortical volumes, or cerebellar volumes. It is clear that significant research has been conducted on the associated neuroanatomy of autism, with a diverse range of brain regions implicated in this neurodevelopmental disorder. Both our small-scale and meta-analytic findings directly contrast this expansive literature. It's possible that volume abnormalities in used publications were simply spread across a variety of brain regions and were subsequently insignificant when analyzed via GingerAile. ABIDE dataset studies have also reported inconsistent findings in brain volume, and among such studies, there's no unanimously affected region of the brain.
Hi everyone, I'm Hassan Hussein and a final year clinical psychology PhD student at the University of Edinburgh. And my particular interested in disorder eating and psychological correlates in people with neurodevelopmental disorder. And this is my part of the thesis, and which is still ongoing project. This project aim is to examine whether and to which extent particle ADHD characteristics are related to disorder eating behaviors and identify the potential factors such as comorbid depression, anxiety, mood problems, and mentalization level autistic traits and the sleeping problems. We designed the anonymous online cross-sectional study and we use a snowball sampling techniques, and participants were recruited from the general population using social media platforms such as Facebook, Twitter, and a total of 1,617 participants completed our online survey assessing their particle ADHD symptoms and eating behaviors. All data were analyzed using SPSS 25 and presented the 3 steps. First is the screening of questionnaire data, which is presenting potential bias between the participant who completed whole survey or not. And the second is descriptive statistic looking for the demographic characteristic and potential covariates between ADHD and non-ADHD diagnosis. And also apply the correlational metrics and the regression analysis before identifying the potential pathway analysis for mediation model. And Wien horizon technique we used to deal with extreme outliers, and also we used process macro for analyzing this model, and our sample size was 908. And the figure 1 is presented our initial findings and the uncertainty hypomentalism assessing from reflective functional questionnaire, and the mood problem, anxiety and depression mood problem we are assessing from the hospital anxiety and depression scale. Both are the fully mediated between the inattentiveness ADHD symptom and disorder eating behaviors. And disorder eating behaviors assessing from 3-factor eating questionnaire total score, and inattentiveness ADHD symptoms assessing for Barkley-Kern scale. On the other hand, hyperactive impulsive type and the core ADHD symptoms is a relationship, and those relationships partially mediated uncertainty hypomentalization and mood problem. Thank you for your listening. If you have any question, please let me know.
My name is Catherine Arkwright, and my poster looks at the healthcare usage of individuals reported as drug-related deaths in Tayside from 2009 to 2014 using an informatics-based approach. So drug-related deaths have been continuously rising worldwide, and Scotland is no exception, with over 1,300 drug-related deaths last year. The majority of these deaths were opioid-related, but users of illicit drugs are known to have generally poorer health. As such, rates of opioid substitution therapy, as well as rates of attendance at other healthcare services in this population, are key for understanding how accessible current healthcare interventions are and where to improve. Previously collected administrative data from NHS databases was anonymised and stored in a safe haven, and then attendance rates and prescription histories for each drug-related death were extracted. A control group of individuals alive on the day the drug-related death occurred were identified from the community and matched on the basis of sex, age, and socioeconomic status. This first graph includes all of the drug-related death and control individuals and highlights that the individuals who died presented at all healthcare services at higher rates than the community controls, particularly accident and emergency and psychiatric outpatient services. They also had higher rates of methadone and antidepressant prescription. This second graph focuses only on the individuals that received a methadone prescription, and again highlights that the individuals that died attended hospital and accident and emergency services at higher rates. Again, the individuals that died also had a higher rate of antidepressant prescription, even though these individuals all belong to a high-risk subgroup of individuals receiving an OST prescription. This final graph looks only at the individuals who died a drug-related death, and these were split by whether they were in treatment, so receiving a methadone prescription, or not. And interestingly, there was no significant difference between accident and emergency presentation, despite previous research suggesting that being in treatment had a protective effect and reduced presentation rates. So overall, our data confirm previous expectations that individuals that die a drug-related death are associated with emergency healthcare at higher rates than community controls, but it also highlights that there is a general pattern of higher engagement with healthcare services, and particularly a high rate of antidepressant prescription, which here we use as a proxy for psychiatric illness. As these attendance rates are high, future research should focus on whether the interventions received differed or if the efficacy of the interventions varied between groups. Thank you.
Hi, my name is Maisie Delph, and today I will be talking to you about basic symptoms in young adults with insomnia. Insomnia is a common disorder characterized by chronic sleep difficulty and significant daytime effects in areas such as memory, cognition, and emotion. These effects are consistently reported, yet patients with insomnia rarely present objective evidence of their deficits. Insomnia also has high comorbidity with other mental illnesses. Recent evidence has suggested that, rather than being secondary to these disorders, insomnia can often both predate and predict them. One such disorder is psychosis. Insomnia is regularly seen in the prodromal stage of psychosis alongside basic symptoms, which are the earliest symptoms that a patient with psychosis would subjectively experience. It can be considered similar to the daytime impacts of insomnia in terms of the domains they cover: thinking patterns, perception, stress tolerance, and language. They're also surprisingly alike in the way in which they are, again, difficult to measure objectively. Thus, we wish to see if we could qualitatively assess any links between the two concepts. Overall, we know that both insomnia and basic symptoms can be risk factors for psychosis, and both are focused on subjective experiences. We wish to assess whether there are any links between the two paradigms, and if basic symptoms are a useful lens through which to view living with insomnia. As young adulthood is the time in which the early symptoms of psychosis commonly occur, we chose to use a sample of young adults aged 16 to 35. To assess our aims, we interviewed a sample of 9 participants who self-screened for insomnia through agreement with 2 statements taken from the SCI-02. We asked questions based around the experiences that comprise basic symptoms and analysed our interview data using inductive thematic analysis. We identified 4 key themes: how I am with regard to others, how my insomnia impacts my cognition, how insomnia impacts what I perceive, and situating and understanding insomnia in my life. These themes independently describe the most significant aspects of our participants' experiences and come together to illustrate the overall impacts caused by their insomnia. Our themes and their corresponding sub-themes are illustrated in the figure provided. Regarding our key aims, we concluded that the basic symptoms paradigm is not a perfect fit to insomnia in 2 key areas: scope and severity. The scope of participants' reported impacts was slightly different than basic symptoms, with alignment in some areas, yet a lack of experiences reported for others. Those experiences that were aligned were also described as much lower severity than would be expected for basic symptoms. We found hints at perceptual disturbance, senses reported as amplified and hypervigilant, but this was not to the extent that would be expected with basic symptoms. However, we did find some usefulness from using the paradigm to assess insomnia, mostly as it allowed us to approach daytime experiences from a novel angle. We found potential for new directions for future research, particularly with regards to language. There's minimal literature linking insomnia and language, but our results suggest a correlation between multilingualism and difficulties in language production when experiencing insomnia. Further study assessing language in monolingual and multilingual participants would be an interesting extension to our knowledge of the disorder. Thank you for listening.
Hello, my name's David Hayward. I'm a consultant psychiatrist at St John's Hospital in Livingston. I'm embarking on a feasibility study to investigate whether measuring empathy anomalies in people with borderline personality disorder could quantify the severity of their syndrome and predict how they will fare through their patient journey. The reasons why I think it is worth investigating empathy anomalies in borderline personality disorder are these. Borderline personality disorder is not caused by trauma. Rather, there is a primary empathy deficiency that is compounded by those non-specific risk factors we see in many mental disorders. Trauma is an example. There appears to be an empathy anomaly that is particular to borderline personality disorder. Empathy has 2 components: cognitive empathy, our ability to imagine someone else's thoughts and feelings, and affective empathy, the emotions that are evoked in response. People with borderline personality disorder have an impaired cognitive empathy, but a normal or heightened affective empathy. See Figure 1. This is not seen in other personality disorders or otherwise matched psychiatry inpatients. The empathy anomaly appears to be trait, not state, because it does not vary markedly with the kinds of variables listed at the bottom of column 1, including anxiety and mood. For these reasons, I think the characteristic empathy anomaly seen in people with borderline personality disorder could be a useful clinical metric. As per column 2, I propose to investigate this by recruiting participants when they are diagnosed in outpatient appointments. The mini international neuropsychiatric interview will be used to describe any Axis 1 comorbidities. The measures of syndrome severity I will use are listed here, as are tools to describe some concurrent characteristics. Cognitive and affective empathy will be measured with a multifaceted empathy test. This laptop task is not burdensome, does generalize to real-life settings, and has been shown to capture empathy anomalies in people with borderline personality disorder. As is shown at the bottom of column 2, 23 emotive images are shown, and participants are asked to choose the most applicable adjective. This describes their cognitive empathy. Another 23 emotive images are then shown, and participants note how much they empathise with the person in the picture on the Likert scale. This describes their affective empathy. Tests will be run at baseline, 6 months and 1 year. As per column 3, Cochrane and Nice have highlighted the need for outcome and syndrome severity measures in borderline personality disorder, and I hope this study might provide an answer. Empathy testing could facilitate matched care in the NHS as well. Thank you.
Hello, my name is Sona An. I'm a second-year PhD student at the University of Glasgow. Hope you enjoyed my presentation. My research is about the South African youth living with HIV who have experienced digital interactions and its power. As you may know, South African youth are one of the most vulnerable population groups to HIV infection in the world. There are more sources of why they are considered as vulnerable. But this study is focused more on the social and cultural aspects of HIV, because HIV treatment is not a one-time prescription but need for lifelong care, and our individual mental health is a product of socially connected performances. In this sense, this study would like to draw your attention to understanding more of why social mental health needed for our individual effort and solidarity, not only physical but also digital world. Then what is the digital power? Why is it important for vulnerable groups? When you use anonymity in the digital world, you may feel the sort of the freedoms of the social responsibility that has been cultivated by your educational system or social relationship. Given the stigmatized circumstance in the South Africa, such kinds of virtual freedoms can empower South African youth to share their story and sensitive topics in the digital world. This study is focused on the process of how they can experience the new transformations of their identity by identifying the gap among the different identities. Based on the semantics literature review, I built up the conceptual framework of 3 different kinds of identity, and it's a dynamic. The numbers one diagrams represents patriarchy society or strongly religious society, such as South Africa and Islamic country. And the number 2 diagrams represents one of the ideal compositions among the 3 identities. Within the particular social situations, youth who explore digital powers go through the possible transformations of their identity journey. Through this process, social identity can be ameliorated. When we think of our mental health, unconsciously, we might consider it as an individual burden only. However, we should consider digital health intervention for HIV youth. Mental health should start from understanding social consensus in a particular society. Thank you.
Hello, my name is Greg Ingalls and I'm a lecturer in psychology at UWS. And today I'm going to be presenting some of our work on poverty stigma that we've been doing with colleagues from Mental Health Foundation, the Poverty Alliance and Strathclyde. So we define poverty stigma first as a process whereby people are stereotyped and devalued either because they live in poverty generally or because they access services designed to help people living on low incomes, such as social security or welfare services. And we're interested in how these experiences of poverty stigma might contribute to socioeconomic inequalities in mental health. So with that in mind, the aim of this study was then to review the existing research that's looked at how individuals experience poverty stigma and how these experiences might then relate to mental health and wellbeing outcomes. So we conducted a rapid review of the literature. We searched 4 academic databases for quantitative or qualitative studies that have been published in the past 15 years. And that produced 22 studies that met our inclusion criteria, 5 of which used quantitative methods. We then used thematic synthesis to analyse the data we extracted from those studies, and that highlighted 2 main findings. The first is that poverty stigma is very complex, and the studies that we reviewed covered several different types of stigma, including self-stigma, received stigma from others, and perceived public stigma. The second main finding was that these experiences of stigma appear to be associated with 4 broad mental health and well-being outcomes. First, we found some evidence that stigma was associated with indicators of mental ill health, including depressive symptoms. We also found some evidence that experiences of stigma lead individuals to develop a negative view of themselves, which then in turn lowers self-esteem. There was also evidence that stigma is associated with general negative affect as well as more specific negative emotions like shame. And lastly, there was evidence that stigma is associated with poorer social well-being and in some cases social withdrawal. So summing up, we think our findings do suggest that poverty stigma might contribute to mental health inequalities, although we do also note an overall lack of quantitative evidence in this area, and we suggest that we now need better measures that can capture the complexity of poverty stigma. It's also important to point out that we focus specifically on individual and interpersonal forms of stigma in this review, and that our review therefore didn't look at structural forms of stigma, including the ways in which institutions and policy contribute to stigma. Overall, though, we do think our findings have implications for policy and practice, in particular because it highlights the need to design public services around dignity and respect. Thank you for listening, and please feel free to get in touch if you'd like to know more.
Hello, this is postgraduate researcher Hasan Burak Eyüpoğlu from University of Dundee. I've got my master's degree in clinical psychology, and currently my main interest area is dissociative identity disorder, which I will call DID from this point. DID constitutes a poorly understood mental health diagnostic category. People diagnosed with DID may report a range of problems such as depression, substance abuse, somatic symptoms, eating disorder symptoms, and panic attacks. In current study, we aim to gain insight into the lived experience of people with DID in an attempt to advance understanding. We used online survey method to gather data. All participants either had received a DID diagnosis or believed they have DID. After demographic information, 5 open-ended questions have been asked related to DID experiences of participants. You can see the relevant details on the poster. Inductive thematic analysis has been conducted for the responses to open-ended questions. 6 main themes have been identified as a result, and I will try to explain them briefly. First theme is lack of body ownership. Participants report feelings that they are not the owner or only owner of their bodies. Body is experienced as shared with other identities or as being possessed by any sort of entity. Second theme is lack of self-coherence. Participant reports conflicts in their sense of selves and in their identity. They complain of not feeling whole. The third theme is loss of memory and time. Participant reports having memory problems, sensing that they are losing time and feeling that they are having shorter life. The fourth theme is multiplicity. Participant refers to their unique experiences as a result of multiplicity. For example, being co-conscious, having internal dialogues in head, gender confusion, etc. The fifth theme is self-harming and suicidality. Participant reports that one of their alters has thought about or attempted suicide and or inflicted self-harm. The final theme is clinical presentation of DID. Participant reports experiencing psychiatric symptoms such as depression, panic attacks, flashbacks, and more. You can see all the symptoms they reported. As final words, exploration of these themes confirms that people diagnosed with DID experience a wide range of difficulties concerning the affective, cognitive, behavioral, and social sphere, and that boundaries of DID are fuzzy and indistinct. Implications for a correct diagnosis and an appropriate and effective treatment plans are discussed.
Hi everyone, my name is Casey. I was working as an assistant psychologist for Greater Glasgow and Clyde's North West Primary Care Mental Health Team. I conducted an audit for the service titled Delivering Virtual Psychological Therapy in an NHS primary care setting during the COVID-19 pandemic. Following lockdown, the team began delivering therapy virtually through video conference platform Attend Anywhere. And the aims of this project were to explore patient barriers to accessing virtual therapy and to understand clinician experiences of delivering virtual therapy. This was done by creating a standardised data collection tool for clinicians to complete any time a patient declined the virtual service that was being offered with a given reason. Clinicians also completed an online feedback survey on their own experiences of delivering virtual therapy. The results found 36 instances when patients declined virtual therapy with a given reason or reasons. And Table 1 here shows the categories which these reasons fell into. Examples of technology issues include a lack of access to technology or not feeling comfortable using technology. Social issues were mainly related to a lack of access to a private space. Choice was when patients could participate in therapy but chose not to. No longer a clinical need was when patients felt that their mental health had actually improved during lockdown. And the other category was when patients noticed an increase in their anxiety, stress, or a lack of motivation as a result of the pandemic, which made therapy not feel appropriate at that time. 11 clinicians responded to the survey, and Likert scale responses indicated both positives and negatives on clinicians' own well-being, confidence, and perceived therapeutic outcomes. Thematic analysis of open-ended responses revealed 5 main themes, all with sub-themes, which we can see here in this diagram. And this is where clinicians acknowledged the positives of virtual therapy, but they also discussed the fact that the therapeutic relationship and the quality of therapy was a lot poorer in comparison to face-to-face therapy. In terms of the patient's quality of technology affecting therapy, as well as barriers in accessing technology or a private space, raised concerns around social disadvantage and digital exclusion, where patients from lower socioeconomic groups might face these difficulties the most. Difficulties with virtual therapy should also be considered beyond the pandemic, considering that prior to COVID-19, there had been discussions around virtual working and virtual therapy being a potentially more efficient way of working in comparison to face-to-face. The fact that clinicians are struggling with their own health and well-being as a result of virtual working is also of concern, and it should be considered in terms of putting service level support measures in place to help staff with any struggles that they're facing. Further recommendations include the use of therapy spaces that patients could go to access technology or a private space in order to access virtual therapy itself. Further recommendations are seeking patients' perspectives in receiving virtual therapy and any potential socioeconomic influences that might affect this. Thanks for listening.
Our poster is on increasing access to early intervention for anxiety for children and young people within CAMHS NHS Lothian. My name is Dr. Gemma Brown. I'm a clinical psychologist along with my colleagues listed here in a small psychology team, the Training in Psychological Skills Early Intervention Children team. And we're partly funded by NESS. We're part of a NESS work stream that is in response to the need for increased access to evidence-based interventions outside of specialist NHS services. And this is something that's recognised across agencies, so we work in collaboration with school nursing, education, third sector and educational psychology to train and coach non-mental health professionals to deliver CBT-informed interventions. And this is with the aim of increasing access to evidence-based early intervention. We work on a number of projects, and this poster highlights 3 of them. And the first of which is LIAM, or Let's Introduce Anxiety Management, which is primarily a school-based CBT intervention that is either delivered as a one-to-one or a group and is around 8 sessions long. And our psychology role within that is to offer training and coaching to the LIAM practitioners. And to date, we've trained around 234 people, and our outcome measures from this, from between October 2017 and March 2020, have found significant improvements in anxiety and low mood, as well as positive feedback from children and young people, and you can see the RCADS data displayed here. However, the delivery of this has been impacted and slowed by school closures, but we do try and adapt this to kind of include the remote sessions as well, and moving back towards doing more face-to-face again now the schools are open. A second project we've been working on is our information sessions or anxiety workshops for parents and carers, and we've delivered 11 of these in 2021 to 336 parents, and they've been, I suppose, a positive outcome of the increased access to things online. And they're generally being positively received. People value them. They say that it gives them new ways to support their child with anxiety. They would recommend them to a friend, and they find that online aspects kind of accessible. And so they're split across 2 sessions, one on understanding anxiety and the second on supporting your child with anxiety. And you can see here a nice quote from a parent who, after going to the sessions, had kind of reflected on their own behaviour and how, after learning about the avoidance cycle and how that maintained anxiety, and thought about trying something differently, which has been really nice to hear. And then lastly, we're also involved in thinking about digital mental health opportunities for early intervention, or part of a test of change for CCBT with children and young people. The research shows that children and young people are more likely to engage with CCBT if they're supported with it. And we've been able to pilot this within CAMHS with some small number of children and young people, and hope to expand this to the community and other CAMHS teams. I've been really encouraged by the positive feedback we've had to date on the work that we're doing, so we hope to keep expanding this with other interventions for low mood, as well as further research and evaluation.
Avatar 2 is an ongoing randomised controlled trial, or RCT, comparing a computer-assisted talking therapy for distressing voices to treatment as usual. In Avatar therapy, a person designs an avatar to represent a distressing voice that they hear, and are supported by a therapist to engage in a dialogue with the voice, aiming to increase control over the voice in everyday life. Avatar 2 is building upon the findings of a single RCT in London, which found that the therapy reduced distress from voices that people hear. It also found that the therapy was safe, with no therapy-related adverse events. Avatar 2 is addressing questions of treatment efficacy, therapy delivery, and its implementation in NHS settings, including testing the provision of an enhanced software platform for the therapy delivery. The main research question is, are both brief and extended avatar therapy effective in reducing distress associated with voices over 16 and 28 weeks when added to treatment as usual in comparison to treatment as usual alone? Participants are being recruited from NHS boards or trusts that are taking part in the study within each of the trial locations. In Glasgow, our primary participating health board is NHS GGNC. We will also be recruiting in Lanarkshire in 2022. People are eligible to take part in the study if they're interested in hearing more about the trial and meet the following criteria: have heard a distressing voice or voices for 6 months or more, are aged 18 or over, currently under the care of a mental health team, have a psychosis diagnosis, and speak English. Participants meet with a researcher to complete an initial assessment before they're randomised to one of 3 conditions. On the first 2 paths, people receive either 6 or 12 sessions of avatar therapy. On the third path, the person continues with their current support before being offered the avatar therapy at the end of their involvement in the study. Everyone then meets with a researcher 16 weeks and 28 weeks after the first meeting to complete a follow-up assessment. The study has been up and running since January, and we're recruiting for another year until November 2022. Patient and public involvement, or PPI, plays a central role within the Avatar 2 trial. For us, PPI means working in collaboration and co-production with people with lived experience of mental health issues, and we believe PPI is crucial to conducting high-quality research. So far in Glasgow, we have welcomed several people with experience of hearing distressing voices or supporting someone who does into our local PPI group. 5 people meet with us fairly regularly to do feedback and give advice on Avatar 2 here in Glasgow. If you'd like to find out more about Avatar 2, please get in contact with me at bridie.rudd@ggc.scot.nhs.uk. You can also find out more information on our website, avatartherapytrial.com.